Hello, everyone. Happy Eclipse Day. It's Michael McNutt, Director of Events and Education with WEDI, and welcome to the Road to Interoperability and Prior Authorization Series, Small Provider Perspective. It's my pleasure to introduce Robert Tennant, Vice President of Federal Affairs with WEDI.
Thank you, Michael. And let me add my welcome on this Eclipse Day. Our goal here is to make the final rule on interoperability and prior auth as transparent and as unobstructed as possible. So with that, we'll go to the next slide. So just for folks that aren't familiar with our organization, WEDI was formed back in 1991 by then Secretary of the U.S. Department of Health and Human Services, Dr. Lewis Sullivan. Dr. Sullivan was a practicing physician and knew firsthand the challenges that providers and payers face in exchanging health information. So he convened industry leaders. He called it the Working Group for Electronic Data Interchange. And they worked on two reports in 1992 and 93. Those were turned into legislative language that became what we know as HIPAA. So we were named in HIPAA as an advisor to HHS, and we've performed that role ever since. We have very close working relationships with CMS, OCR, and ONC. And in fact, CMS and ONC serve on the WEDI Board of Directors. We do most of our work through our work groups, which I'll talk about in a second, but we have multiple forums like the one you're attending today. And our goal is to convene the industry, not to point fingers, but to solve problems. Next slide. As I said, we do a lot of our work through our work groups, sub-work groups, and task groups. And you can see here, we have 18, ranging from things like privacy and security, Surprises Act, each of the major HIPAA transactions, health equity, emerging technologies, and others. So we do a lot of work. If you're interested in getting involved in our work groups, as a reminder, if you are a member of WEDI, everyone in your organization is a member and can participate in these work groups. Next slide. So we are coming to the end of our series. We've had, how many? We got 4, 5, 6, 6 so far that we've completed. We have one more after this one on Wednesday focused on small payers, but all of the other ones, including a wonderful overview from CMS, they're all available on our YouTube channel. And I would encourage you, if you have an interest in doing deep dives in some of these other issues, take advantage of this education opportunity. Next slide. We could not bring this type of education and this series to you without the wonderful and generous support from our sponsors. Both Edifex and MCG are experts in the field of interoperability and prior auth. And if you have any interest in applying these technologies to your organization, these are the two vendors that I would strongly encourage you explore. Next slide. We are hosting what we're calling post-game shows, which are sort of a deep dive in some of the issues, concerns, questions raised during our interoperability education series. It's being led by our own board chair, Ed Hafner. And again, if you're interested in sort of doing a deep dive in some of these issues, our goal is to identify some issues that may need clarification or guidance from CMS and being able to get those to the agency. If you're interested, please contact Ariana Poole at apool@wedi.org. Next slide. As many of you know, WEDI was instrumental in helping the industry move forward with HIPAA transaction versions 4010 and 5010, as well as the ICD-10 diagnostic code set. So we are going to take on the same role for this final rule and help industry stakeholders adopt these interoperability and prior auth final rule. So how do we do that? Well, obviously through education like the session you're attending today. We also develop work products and conduct surveys. In particular, with this rule, we're going to seek to identify a return on investment to assist those not covered under the rule move forward. We'll spotlight early adopters and identify best practices. We'll, as always, continue to communicate directly with CMS with recommendations. And we'll be hosting an online community forum to allow folks in the industry to ask questions, raise issues, and have a dialogue with their colleagues. Next slide. So in terms of today's agenda, I'll walk through an overview of the final rule. Then we'll have a tactical overview by one of the leading national experts on APIs, Bob Dieterle. And then we'll turn to our expert panel. We've got a number of prepared questions for these experts, but I would also encourage you to include your questions in the chat as well. So if you go to the next slide, Michael, we'll just talk about that for a second. You do have the opportunity. This is a unique opportunity for you to ask questions of national experts and certainly use that chat feature to either ask questions, raise issues. And as always, the slides from this program and the full recording will be emailed to you following the event. Next slide. So let's talk about the rule. Obviously, it's a huge rule with so many provisions, but I'm going to hit some of the highlights that especially that will be focused on with our panel later. So next slide. So the rule was officially released January 17th. And I've put a link here to the final rule. It makes for excellent beach reading if you're looking for something like that. Very importantly, the impacted payers are Medicare Advantage, state Medicaid and children's health insurance programs, Medicaid managed care plans and CHIP managed care, and qualified health plan issuers on the federal exchange. So this was a very important expansion from the first proposed rule that came out in December 2020, which did not include Medicare Advantage plans. And who is impacted on the provider side? Well, either eligible hospitals or critical access hospitals or eligible clinicians who are participating in the MIPS program. As we'll discuss a little bit later, they've included some EPA requirements in that, but it does not preclude, and it's very important to note, any health plan and any provider can take advantage of these rules. So it's not strictly limited to these entities. Anybody who has the technical capability can support the APIs. Next slide. So some of the provisions in the final rule include something called the Patient Access API. So this is an API that allows the patient, and the patient will decide for example, which app they want their data sent to, but the health plan must support that and send the data directly to the app of the patient's choice. The Provider Access API is very similar in that the provider can reach out to the health plan of their patient and ask to get a number of data points from the health plan, including data stemming from claims and encounter data. Does not include remittance information and cost-sharing information. The U.S. core data for interoperability data and prior authorization information, excluding drugs, that must be made available to the provider by the payer. And then the final one is the payer-to-payer API. So for example, it's very common for patients to change from one insurance carrier to another. The patient can say, I want all of my data from the old payer to be sent to my new one. And again, if it is all the impacted payers must support all three of these APIs. Now, there's another API, and we're going to spend some time on that, and that is for prior authorization. And then the rule also goes on beyond APIs and includes some opportunities to improve prior authorization processes, and we'll talk about those as well. And finally, as I mentioned, there are incentive programs currently available for not all providers, but in particular those that have Medicare patients. And there is a new measure for electronic prior authorization. Next slide, please. So the prior auth API, the compliance date is January 1st, 2027. So health plans and providers do have a little time to get ready. The impacted payers must implement and maintain a prior auth API that includes the following: something called CRD, Coverage Requirements Discovery. And very simply, that is the provider wants to know if a particular service requires a prior authorization. This allows them to get that information from the health plan. The second is known as DTR, Documentation, Templates, and Rules. Essentially, that is information sent from the payer to the provider saying, here is the template, the questionnaire that you must fill out. Here's the data that we need in order to make an authorization decision. And then the third is PAS, Prior Authorization Support. And that is the back and forth, once the health plan has the data, the back and forth to make sure that the payer can respond in a timely manner and let the provider know if an authorization has been granted or denied. Next slide. So in terms of, back one, yep, thank you. In terms of improving the process itself, the compliance date's a year earlier, so it's January 1, 2026. And again, impacted payers must do the following. So they must make a decision on the authorization. Once they get all the information that they require, they must make the decision within 7 calendar days, and for expedited prior auth decisions within 72 hours. However, this policy does not include qualified health plans on the federal exchange. If they do deny a service, they must provide a specific reason for that denial. And then finally, they must report a number of metrics. So, for example, the number of requests that were approved, the number that were denied, the number that were approved after appeal, and the average time between submission and decision. Next slide. And so, as I mentioned, the hook to try to get providers to support the technology is by including a measure in the merit-based incentive payment system and the EHR reporting program. So these are pushed out a little bit. So we have the calendar year 2027 performance period. And again, the two participating programs, the MIPS on the physician side, and then the Promoting Interoperability program on the inpatient side. Now, a big change from the proposed rule, the electronic prior authorization measures are now yes or no, instead of what they had proposed, which was that the provider would need to capture the numerators and denominators. And again, if you are participating in one of these incentive programs, you'll simply need to report a yes response or claim an exclusion in order to satisfy the CMS reporting requirements. I will say that we are expecting a regulation from the Office of National Coordinator for Health IT. It's called the HTI-2 rule, and that is expected to include API support in its EHR certification program. So that would mean a provider would have access to certified technology, which would include APIs. But again, the rule is not out, but it could come out virtually any day. Next slide. So I've taken a few slides here, and I want to, of course, thank CMS for making their slides available to us. You can see here there are a number of required standards for many of the APIs we've been discussing. I won't go through all of them, but the next slide talks about those that are recommended, not required. That's it. So we'll get into this with the panel, but it is an interesting decision. And Bob Dearly can tell us a little bit more about it in his talk. But they are strongly recommended, and that includes the three APIs that I discussed: CRD, DTR, and PAS. Next slide. And CMS has a number of resources available on the rule itself. They've got a fact sheet. They've got frequently asked questions. And they have a number of technical standards and implementation support resources as well. So a lot of hyperlinks, but a lot of good information. And they have made available their experts. So if you do have a policy question on the final rule, they have an email address here, CMS interoperability at cms.hhs.gov. So again, if you've got a policy question that you want an answer from CMS on, that is the email address to use. Next slide. So with that, I am pleased to turn the program over to Bob Dieterle, who is a CEO and owner of Enable Care and is also the HL7 Da Vinci Project Senior Advisor and Burden Reduction Lead.
Actually, Rob, it's Mike. We are still waiting for Bob to jump on.
Okay.
So maybe we can address Janice's question in the chat, and after that, we can go to the panel, and Bob could just jump in when he can.
That sounds good. Thank you. Okay, so Janice's question is, have you gotten any confirmation that HTI-2 rule includes PA-related certification? Well, the national coordinator, Dr. Mickey Tripathi, did speak at our October conference, and I candidly asked him that question, and he kind of winked and nodded. So I took that as a yes. The most important thing is the providers have to have the technology in place in order to take advantage of these APIs. And in order for the APIs to be included into the MIPS and the Promoting Interoperability incentive programs, there has to be certified technology to support it. So I am pretty confident that at some point we'll see the certification requirements include these APIs. But I see, Andrea, you've got your hand up.
Yeah, I was just about to pop in the chat as well. HTI-2 is on the unified agenda, and it expressly mentions electronic prior authorization APIs within that. And also, if you guys remember that electronic prior auth RFI that ONC put out, I believe it was January of 2022, that is now linked to HTI-2 in the unified agenda. Yeah, and then I see Heather also popped in the blog post that also mentions it.
Excellent. So again, we're pretty confident that it's going to be in there. The question is, when are we going to see it? And one of the comments that WEDI has made over the past couple of years is the importance to synchronize these rules to make sure that, for example, vendors aren't required to develop certified technology a year or two after the compliance date for the industry to move forward. So there needs to be that harmonization, and I think certainly they understand that as well as we do. So that's I guess to be determined, but keep your eyes open, and hopefully we'll see that ONC rule shortly. So with that, maybe we'll go to the next slide, and we'll have our panelists introduce themselves. And what I've asked for is sort of just a brief overview of your organization, and then sort of your initial takeaways from your read of the final rule. And maybe we'll start with Rebecca.
Sure, absolutely. Thank you. Hi, everyone. Rebecca Fee, and I'm the Director for Dental Benefits Coding and Data Exchange at the American Dental Association. So I like to tell people that just basically means if data has to go from point A to point B, I'm involved there. The American Dental Association is really committed to administrative efficiency and burden reduction. We're working really diligently on these topics, and while prior auth itself is a very small impact to the dental industry and for the small providers, I think it is a opportunity. And I think what you'll probably hear from me the most is just as Rob said, it's not limited, right? So providers and payers can choose to do this, even if they're not obligated to do it. Much like certification, right? Dentists don't use ONC certified health information technology. They don't have to. But what we keep sort of reinforcing in the industry and in my talking points is, hey, why, as a technology vendor, why wouldn't you want to be ONC certified? Why wouldn't you want to be meeting the rest of the healthcare industry where they're at? And what a great way for you to sort of promote your own business, if you will, and take a corner of the market and get certified. So while some of the things that are directly related to this interoperability and prior authorization rule may not have a huge impact on our industry, it's certainly opening a door or a window, or maybe pulling back the blinds a little bit to ways that the dental provider and the dental payers and the rest of the dental industry can get involved in some of this health information exchange.
That's great. So next we'll go to Heather, and welcome.
Hey, Rob, thanks so much. Hey, everyone. I am Heather McComas. I am Director of Administrative Simplification Initiatives at the American Medical Association. My team works on reducing administrative burdens for physicians and their staff, and so prior authorizations, of course, very much within the scope of what my group at the AMA does. I think that overall, the AMA's take on this rule is quite positive. We're very grateful for administration taking this issue so seriously. It's certainly a top priority for our members that this onerous process get reformed, particularly because it interferes with patients getting the care that they need in a timely fashion. So some particularly good things that we saw in the rule, some things that Rob mentioned as overviews. First of all, is the improved transparency, the fact that plans are going to be required to provide a specific denial reason for all prior authorizations, and also the requirement to start reporting metrics regarding their prior authorization program. We think that's really important, and it will kind of push everyone to do better, given the fact that they have to make this information public. We also think it's really important that the prior authorization technology that we're discussing today in this rule is embedded within physicians' electronic health records. I know for years that there's been a lot of focus on health plan portals, and while those are electronic and they might represent efficiency from the health plan's perspective, they are not efficient for physicians because they have to manage their portal, logins and passwords for every single health plan that they do business with, and re-enter data from the EHR. So we think it's really important that the technology we're talking about today is actually embedded within the EHR and it keeps everything within that EHR workflow. So that's really important too. I'd say that, just always to have one thing to want to be better. The one thing I think we were disappointed about was the decision timeframes that are required by the rule of 72 hours for urgent prior authorization decisions and the 7 days for regular prior authorization decisions. We think that those are way too long, particularly that 72 hours for urgent care. I think that any of us who've had a urgent medical condition, we have not wanted to wait 72 hours for an approval to get that care. So we are hoping that that's something that will be shortened in the future, particularly as we have these new technologies that will hopefully make everything much more efficient and allow health plans to provide decisions in a much more timely fashion. We're hoping those timelines will get shorter as we move forward. But overall, we have a very positive view on this rule, and we are excited to see being implemented over the next couple of years. Thanks.
All right. Thank you, Heather. And Dr. Summer Kalal, welcome.
Sorry for being late.
No, good afternoon. So Summer Paul Kalan, I'm Chief Medical Officer at EdFX. And for those who aren't familiar with EdFX, we're a health technology company based out of Seattle. And, we work pretty heavily in standards-based interoperability, have done so for many years, and have been heavily involved with WEDI and the Da Vinci Project. In particular, a lot of the interoperability we work on is on the health plan side, connecting health plan systems within the four walls of the health plan, and also connecting those health plans externally to the stakeholders they need to connect to in order to be able to share data. So as it relates to this particular topic, it's one that we've been very close to. And I'll say for me personally, it's one as a physician myself and my wife's a dentist. This is something we actually talk about when we sit around the house. How we share information or deal with some of the elements of providing care for patients that relates to being able to interact effectively with a health plan. So, from my perspective, it's important not only to have the spirit of interoperability, because I think we all share a spirit, but it's important really to do it effectively. And being effective at it is not only being able to connect with the large IDNs, the large health systems that are out there, but also, as was alluded to by others earlier, being able to connect really to every medical practice, and in doing so on behalf of every patient or every member or beneficiary of the health plans that serve these folks in a way that it feels like a seamless system. And I know that's been one of the challenges with interoperability generally to date, even beyond this topic of prior authorization. Even when we have interoperability, it doesn't always feel seamless. So it's important here that as we embark on implementing an electronic approach to prior authorization, that hopefully we can do so in a way where it feels for the patients who are all ultimately serving that things are more efficient, more seamless, and they're able to get access to the appropriate care that they need. So appreciate the panel here, and thanks for the opportunity to join.
Thank you for being here. And next, we'll go to Arna.
Hey, good morning from Oregon. Good afternoon to everyone east of me. My name is Arna Meyer, and I'm with Albion Dental Technology Consulting. I have a unique position in the industry. I mirror a lot of what Rebecca says. I'm the dental sub-work group co-chair over at WEDI, and what I have been working towards is technology implementations, and I work primarily with the providers and provider groups, and in the realms of practice management software and revenue cycle management. And where this rule is really interesting to me is, especially as it pertains to dentistry, is we don't have a lot of federal participation in payers and in the dental industry specifically. And so this will be, for the most part, a voluntary request or a voluntary movement within dentistry. But as we look at dentistry and the trends as a whole, as an industry over the next 10 years or so, with movements into the Medicare Advantage plans, but also with the discussions around the oral health integration, dentistry really, we need to start thinking about how we can connect into the greater medical system as a whole. And we this is one huge opportunity for us to start making some strides in that regard. And so I'm really excited to be part of these conversations and to help bring the dental industry into these discussions, because we could use all the help we can get. From a technology standpoint, we are lacking on the infrastructure, and this is a huge opportunity for us to step up and build out some of that in collaboration with the medical industry together, so that we have this infrastructure and we can support and we can work a little bit more seamlessly between our different fields, because dentistry, that's what we have patients that are coming in every 6 months pretty routinely. We are a huge opportunity to help provide healthcare and not just dental care. And so this all comes into the same conversation. It's providing access to care through infrastructure and technology. And it's a pretty exciting place to be. And I'm very grateful to be part of the discussions too.
Thank you, Arna. And we'll go to Stanley next. Welcome.
Good afternoon. This is Stanley Nachimson reporting from Florida, where we're only going to get a sliver of the solar eclipse. But while I support the initiatives in this final rule and the opportunity for better connections among providers and plans and patients especially, the one concern I have is due to legal restraints. This rule does not cover every health plan, doesn't cover every provider. And I'm a little concerned about some of the confusion that might occur when providers attempt to use these APIs with some plans and find that they don't work because the plan has chosen not to support it. It's not one of the impacted payers. And then are able to do some work with some of the payers that do support it. Whether or not it's included in the electronic health record is certainly I expect the vendors to make that capability available. What the charge for it might be and whether a provider decides to implement that is going to be an excellent question. So I think there's some concerns in implementing the requirements of this rule, because it is not as widespread as, for example, the HIPAA requirements. And just as an aside, in our discussion about the HIT2 rule, it did go to OMB in mid-January. It's on their calendar. Generally, they take roughly 3 months to review and approve a rule. So I would expect to see that HIT rule out within the next couple of weeks, Rob. So something for all of us to look forward to.
Yep. Excellent comment, Stanley. Thank you. And last but not least, Andrea, welcome to the program.
Yes, thank you so much for having me. I'm Andrea Chrysler. I'm Senior Associate Director of Administrative Simplification at the American Hospital Association. So as the AHA, we represent, all hospitals from, of course, the largest, most sophisticated systems down to, individual hospitals, including some rural hospitals and those community hospitals. So very much a diversity of membership. And as far as the AHA's kind of take on the final rule, I will say that we are very much in lockstep with a lot of what Heather mentioned from the AMA side. So overall, we are thrilled with the final rule and have no complaints. There are some areas where we think CMS could push a little farther, being those timeframes, as Heather also echoed. As well as expanding the rule to potentially drugs covered under a patient's medical benefit, so that the rule also encompasses drugs like chemotherapy and infusion medications. But overall, we are very excited about FHIR and the technology in the rule. We think it's incredibly promising. But we do have, some implementation concerns, I think, as many mentioned, with ONC certification being part of this. So we will really be monitoring closely and making sure that what we think is a fantastic rule is really meaningfully operationalized.
I appreciate that, Andrea. And I'll just say on the drug side, the nice thing about the rule is it doesn't prohibit a payer from supporting prior auth on the drug side. It doesn't require them to, but that's one of the things we'll be watching for, to see how expansive health plans are in their interpretation of the rule. And we'll get a better sense of the technology behind the rule from really one of the leading national experts. And Bob Dieterle, thank you so much for being here and for sharing your vast knowledge on this.
Okay, well, thank you very much, Rob. I appreciate that. And I appreciate the opportunity to participate today. Let me share my screen. Will I be able to do that? Okay, yes, apparently. Okay, are you able to see my screen?
Yes.
Move that off. That doesn't work. Okay. For a little background, I have the privilege of being one of the founding members of Da Vinci at HL7, which is the organization that has been responsible for developing a number of these fire implementation guides, some of which we're going to talk about today for prior authorization or burden reduction. I have also been one of the founders of the ONC Fire at Scale Task Force, looking at how we scale all of this technology in the industry. In addition to that, I'm the architect and use case lead for all of the burden reduction implementation guides, which we'll be discussing today. This will give you an opportunity to go and put into focus what we're going to say based on the role I played and the participation of hundreds of other people in trying to make what was a concept a reality. This to work right, there we go. We started out by looking at the challenge we had with prior authorization and its impact on patients, its providers, payers, and we set a set of goals for ourselves. What we wanted to do is make sure that patients experience a more rapid treatment approval. We wanted them to be able to participate in their care decisions, which means we have to bring certain decisions to the point of service, the interaction between the provider and the patient. And we wanted to have the patient and provider able to discuss alternatives for treatment based on what was going to be covered, what was not going to be covered, for example. For providers, we wanted to improve the information workflow. Right now, it's any combination of portals, faxes, telephone calls. It is a combination and some transactions through the X12278. So it's a combination of many things and doesn't work particularly well for anyone. We wanted to reduce having different payers look differently to the provider, having a common way to go and connect to each of them and a common way to express their requirements. And we thought that this would be effective in both improving turnaround time, but also in eliminating first-time denials, reducing data entry errors, et cetera. And we think that, by addressing key issues in the workflow that we have between providers and payers regarding prior authorization, we believe that we could, over time, achieve the goal of real-time approvals during the process of ordering or shortly after that when things are assigned to particular providers to perform, and be able to go and inform a patient before they leave the practice as to what the next step is in their care so that they can schedule that appointment in advance of leaving. We want to try to address the fact that roughly 30% of all patients that leave a setting of care that do not have the next step in their care plan already available to them do not show up or do not follow through, and ultimately wind up coming back into the care settings in a much more expensive way, through emergency room or through hospital admission. In looking at the problem that we were facing, we looked at three different pieces of it. One was the ability to determine that something was necessary. In other words, you had to have prior authorization for a particular service or product. We call that coverage requirements discovery. It is much broader than just prior authorization, but it deals with prior authorization, determining that something's necessary. We then wanted to deal with the fact that it's complex for a provider to collect the information that a payer needs, and in fact is very difficult to do when different payers may have different requirements, information requirements, to show medical necessity and appropriateness. So we wanted to automate the process of collecting the supporting documentation, which is what we're calling documentation templates and rules. And then finally, what we wanted to do is to turn around and automate the submission of the prior authorization requests and the supporting documentation to the payer. And finally, if additional documentation is required, we want to automate the ability to go and collect that and exchange it also using clinical data exchange. Now, what's happened in the final rule from CMS is the enforcement discretion from the National Standards Group. And what this does is it no longer requires that we have to use the X12-278 for prior authorization. Now that opens the door to a whole host of possibilities here, not just exchanging FHIR bundle at this point in time, meaning prior authorization, but actually being able to do prior authorizations at any point in the clinical workflow, during coverage requirements discovery, for example, or during documentation templates and rules. So we have the ability to very early on in the clinical workflow process, submit information electronically and get an authorization without going through the formal process at the end with prior authorization support. So coverage requirements discovery, this is actually a second version of the implementation guide. This one was published in October of 23. There was a prior version that we had out that had less functionality. This one has pretty much covered all the bases that we have been trying to cover, with the exception of the enforcement discretion, which we'll have to look at on another version coming out this year. What we're doing here is we're trying to take the guesswork out of what happens at, for example, the time that a provider is signing the orders, or the time that you are asking for an appointment, or the time that a back office decision is being made as to who should go and perform a particular service, meaning, you know, is it going to go to this imaging center or that imaging center or a particular specialist? And so we want to automate that process. So what it does is it uses something called CDS hooks, which is the technology that can be baked into the clinical workflow. And when that activity happens, signing an order, for example, a message gets sent directly to the responsible payer, indicating that that order has been placed and here's the supporting information. It also includes with it the ability to access the patient's clinical record, assuming the EHR allows that. Okay, we're not overriding security here, and gather more information. So as an example, at the time a provider may be ordering an MRI, the payer has logic that says, okay, if this is for, let's just say, for example, a torn ligament in the knee, the diagnosis is a torn ligament. Well, the first thing we have to do is make sure there's no bone involvement. So have we done an X-ray? Well, if we've done an X-ray and it doesn't show bone involvement, then we're going to approve the MRI. That all could be determined at the order time. So within seconds, the prior authorization could be approved, rather than going through the process of creating documentation, submitting documentation, waiting hours, days, weeks for the approval. This is a graphic of the various points in the clinical workflow where we have the ability to use coverage requirements discovery to go and get information regarding what services are covered by the patient or the patients, or shall we say the members plan, and whether or not they require specific documentation or require prior authorization. So we can do this at appointment book. We can do this at the start of an encounter. We can do this when the orders are being created. Now, this one's a really interesting one. It's optional, but it would allow you to interact, for example, and provide guidance on the selection of particular services. And then at order sign time, which is typically what happens. You order something, you order lab tests, you order other diagnostics, you order treatment, and you sign that. Order dispatch, which is when the back office has decided where that particular service should be rendered. What we've done is, and these are all automated pieces. These are inside of the clinical workflow, inside of the EHR. The provider should not have to do anything to trigger these or to get the response back and take appropriate action, unless that appropriate action involves the provider making a decision or interacting with the patient to describe, for example, what's covered, what's not covered, what's covered in network, et cetera. We also provide in this workflow the ability to go and add a new patient to a payer's attribution list so that another capability of the CMS final rule provider API can take into account a brand new patient. So during appointment book, you could declare a relationship with that particular patient and therefore have access to the payer's information, assuming the payer allows it. The same thing could be true at encounter start. For example, walking into an emergency room or going into a hospital for the first time. These are things that we've added to the workflow in coverage requirements discovery so that we can enable other services, enable the provider to get information so they can make a better clinical decision. Documentation templates and rules. Again, trying to automate the process of gathering information to support medical necessity and appropriateness. This is also a version 2. We have added new capability to this version that didn't exist in the original. That's primarily because there are new standards that got created, something called adaptive forms. Up till now, you'd fill out a questionnaire, a FHIR questionnaire, which would take information from the clinical record. We can pre-populate questions and then provide that feedback to the provider so they can affirm it, they can change it, they can add information that couldn't be found. But what we have with the new version is something called adaptive forms, which looks much more like a portal interaction. So in other words, you can ask a question, the payer can ask a question, it can go to the EHR, answer the question, assuming the information is available, return that to the payer, and the payer can then ask the next appropriate question conditioned by the response to the prior one. So if you think about it, if you're walking a very complex clinical protocol, heart disease, respiratory complications, where you may have hundreds of nodes, you can walk only those nodes that are necessary, assuming that the answer to the prior question conditions a particular branch. So it makes for a very efficient way to go and ask for information. It also becomes an interaction between the provider or the EHR and the payer, which allows us to turn around again. And at that point in time, assuming the payer has all the information they need to go and authorize whatever service is being requested, they can do it right then. They don't have to wait and formally submit it through PAS. So we have the ability to shortcut the process, again, to improve turnaround time, both for patients and providers. This is the overall flow. We automate the process of assembling information because this standard can go out and reach into the EHR with permissions. Gotta be careful here. This doesn't override security. It works with whatever security is in place and pre-populate the questions. So if a question is there a specific diagnosis, or what's the list of medications, or have you had a particular procedure, it can go out to the clinical record and find that information and pre-populate it. So the provider doesn't have to enter it. The intent is over time to gather all the information automatically and be able to present it to the provider just to approve submission. rather than have them go through any process that's necessary to go and fill in a form manually. So we're automating that entire process also with these new standards. So the documentation templates and rules can be evoked from a number of places in the clinical workflow. It can be initiated as part of a follow-on to coverage requirements discovery. It can be delayed. So for example, a provider may say, I don't have any time to deal with any of this, even if it's only one question I have to answer. And it may get allocated or to the back room, the back office. You may want to relaunch. In other words, there may be questions that you answered the 3 you have to do in front of the patient, and you want to do the rest of it later in the day. You can suspend it and relaunch it with the full context of when you suspended it. And you can do a standalone launch if, for example, whatever you're doing, you're not invoking CRD, for example. Finally, prior authorization support. This was the last step in the process. This is where we turn around and take the information about the services that are being requested or devices or referrals and package it up with the supporting information that has been created through documentation, templates, and rules, and submit that to the payer for evaluation. This is the normal 278 exchange process, along with what would be typically in a 275, if you're comfortable with X12. So submitting all of it. So we basically turned the entire workflow upside down. It used to be you ask for authorization for this. The payer says, yeah, I need the following documentation. You gather the documentation, you submit the documentation, and then you wait to get a response. What we're doing on the very front end is electronically identifying the documentation that is necessary, collecting it through an automated fashion, and providing the ability at various points to go and shortcut the prior authorization process. And still, if it's necessary to go to a formal submission, which it may be because they may not have all the information they need, there may be a reason that they have to do a manual review, you have the ability to automate the submission of both the request for prior authorization and the documentation. So it works, it looks like this in the flow. With the 278 in place, we translate from the FHIR bundle, which is the FHIR representation of the information that's necessary to support the 278 and the attachment, and then transform it potentially back on the other side. Remember, we have to meet HIPAA requirements, assuming this is before the enforcement discretion. We had to have the exchange in the 278 format at some point between the provider and the payer. Now with the enforcement discretion, this transformation is no longer required. The entire thing can be done with the FHIR bundle, assuming that's what's being supported. It's not a requirement that it be done that way. It's not a requirement to use the 278. You now have the option of doing either one. So at this point, with the enforcement discretion in place, it looks like this. We're exchanging FHIR bundles if we wish to. When you get a response back from prior authorization support, in other words, from the 278 response, it may be there's still a need for additional documentation. It may be that what was submitted it raises a question. For example, you submitted a list of medications or procedures that have been performed, but because of the combination, there's a need for an additional question to be answered, or there's need for an attestation on the part of the provider. What we have here now is the ability for the payer to respond back in the 278 or through the FHIR bundle and say, I need the following information. That following information could be some document that's available on the EHR. We can automate the process of retrieving it by using LOINC codes or using some of the X12 custom codes for documents. Or we can turn around and come back and the payer can say, I have an adaptive form or I have a questionnaire that needs to be filled out. and we can actually use DTR to do that, and then submit it back through a capability that's part of what's called CDEX, Clinical Decision Exchange, Clinical Data Exchange, excuse me. So this is the overall flow from the beginning to end. Very complex flows internally. This is probably one of the reasons why we haven't automated this today. It's taken time to define all of the various pieces that are necessary to be implemented. But if you think about it, this part over here is typically the EHR, and this part over here is typically the payer. We show it as a more elaborate breakout by a number of roles. So this could be the provider, the back office, the EHR, CDEX, the DTR application, an intermediary could be part of this, CDS service, DTR endpoint, et cetera, et cetera, et cetera. And we do this intentionally because not every implementation looks the same. All right. We're not black boxing the payer. We're not black boxing the provider. We're providing information on the kind of exchanges that may need to take place internally, but also may need to take place between various modules or various business associates. The parts in pink are the parts that always go over the wire. They're the electronic exchange. You have to do those as electronic exchange. The parts that are not in pink could be part of either the payer, the provider, or some standalone module. So bottom line is, what we're doing is we're standardizing interactions across all payers and providers. A payer sees all providers the same way. A provider sees all payers the same way. The exchanges are identical. Doesn't matter who you are. The data that's being shared is largely computable. And we do this by integrating it into the clinical record and into the clinical workflow. This should not be overly obvious to a provider or the patient. This is something that should be handled electronically in the background. The only time the provider or the patient should have to interact with this, and I mean the patient through the provider's interaction, is if there's something that is not available in the clinical record that needs to be dealt with at the point while the patient's in front of the provider. So we're dealing with common workflow expectations. It doesn't matter what specialty you are. It doesn't matter whether you're in a hospital or whether you're in a office practice. We're looking at the same clinical workflow process. And we minimize the collection of documentation by asking only for those things that are absolutely essential. This isn't send me a copy of the last encounter or send me a copy of the medical record. It's send me these 3 elements. And we're reducing burden. We're avoiding duplicate entry. And we have the ability, given the flexibility of the FHIR profiles and the underlying resources, to add new capability as it is needed. It is much more flexible than we've had in the past, where it took years and a major release, a major pain to provide updated functionality. And I believe that is it. And I'm going to hand this back over to Rob.
Bob, excellent overview. And what strikes me as an analogy is, we don't all know exactly how a car engine runs, but we know how to turn it on and drive. And I think that's the point you're trying to drive home. Beneath the engine, there's a lot going on, but the most important thing is that the clinician will have the ability to move this data right in their workflow. I think that's a lot of the excitement about this final rule.
Absolutely.
So let's engage the full panel. And I want to talk first about this provider access API. So just as a refresher, this is the ability for the provider to reach out to their patient's health plan and gather data. So the question is there value in that? And if there is, where is the value? So I'll open it up for hands, but maybe I'll start with Heather. As a physician, if you are, as in particular, getting a new patient, you probably don't know much about them. And would it be helpful to reach out to their health plan especially if they've had previous health plans and we're able to consolidate the data. How helpful would that be to a physician?
Yeah, thanks, Rob. I think it definitely has the API, the provider API does have the potential to be helpful to physicians and other providers. I think the question is, as they gain experience with it, what kind of data are they getting back from the plans? Is it more, better, different than what they would get through doing an exchange directly to another provider that they are aware that the patient has seen? So I think it's the devil is going to be in the details, and it's going to be the ease of use of the APIs and their experience with it that's going to determine whether or not they start really turning to the API as a reliable tool. But I welcome to hear what everyone else thinks about this.
Yeah. Kayla? Yeah.
Yep, thanks. So, I think from a provider perspective, there is that question that Heather kind of raised of what would you do with it if you had access to that data? And, I think maybe the best analogy, if I think about in the pharmaceutical world with prescriptions, the access to a medication history from a pharmacy benefit manager and or the pharmacies through SureScripts, it's really helpful as a provider to be able to see that kind of information and reconcile it against a patient's medication reconciliation list that they bring in themselves, or that may be already present in the electronic medical record. So I could definitely see opportunity in this model as well to be able to get a better sense of what kind of disease states have been previously documented, what kind of care has been previously provided, especially if a patient has recently switched health plans and doesn't have immediate access themselves for that. So I do think there's probably a learning period of saying, if I could access this, what would I do with it? But I could certainly see that analogy there to what's available through e-prescribing these days and being able to leverage that.
Excellent points. Andrea?
Sure. I think the Provider Access API is a great opportunity. I think it can really go a long way in getting a more complete picture of the patient that is in front of you, to further things like care coordination and such. I know I mentioned this silly example last time on WEDI, but I seek care at 2 different systems within the area. So it could potentially be really helpful if each of my, providers in different systems are able to pull my full history and see what was just done at these disparate providers, giving them a much more complete picture of my medical history, and also alleviating some of the burden on me to provide that history to them, which I think inevitably would, be a bit flawed, and I may not show the full picture, or I may not know the correct terminology. So I think it shows great promise, and I think, hopefully there is good provider uptake to recognize the full benefits.
Excellent points. We'll go Rebecca, Arna, then Stanley.
Yeah, I think this would be a great opportunity for dental, but there are going to be some limitations there. Just like what Heather was saying, that we have to assess the information that's getting back, especially on the dental side. We only send in the information that's needed for adjudication of claims. Like, it's fairly limited. So if you're looking for what I'm going to call the surgical history of a patient, great, you can probably get that back. You may be able to get information that's not even in the clinical record right now, like implant lot numbers and things like that may have been attached for the adjudication of the claim, but it's not going to paint a whole picture. So again, we have to speak to it as an aspect that makes it possible, but there's still a long way to go on having a complete picture of someone's sort of engagement with oral healthcare.
Yep. Excellent point. Arna? Yep.
Yeah, to add to what Rebecca was saying, where there is an opportunity in dentistry, really where I see it lies in treatment history from a dental perspective, especially for pediatric patients. There are a lot of frequency limitations that dictate payment of claims. And so where there right now is kind of a deficiency, where this could be a huge opportunity, is actually getting a comprehensive breakdown of prior history, treatment history of those patients. To Rebecca's point, it's going to be interesting to sort of think about how we practically implement this, because there is a need for, I try not to differentiate too much, but there is a potential need for differentiation of service codes. So as we get that information back, there is an opportunity there to have access to that information so that we're providing care for patients in a way that can be like reimbursed for the providers, and that the patients aren't incurring unnecessary costs because they get within those cycle times.
Excellent points. Stanley?
Hey, thanks, Rob. I think we have to worry here about information overload. If there is an opportunity for providers to segment the information that they get, I mean, that's great. But if you're going to a health plan and say, well, I want the patient's information, and you get 4 years worth of information, since we're really talking here about small providers, I'm assuming with somewhat limited resources, I think you have to be very careful here in what gets provided, what gets sent to the provider, and how well they can analyze it. Perhaps once a year to go to the health plan and get a set of information for a patient, that's great. Maybe if there's a new patient, that's great. But again, if you have a lot of information coming in on a new patient, you're gonna sort of step back and say, maybe I don't need all of it. So if there is the opportunity, and perhaps Bob is going to answer this, to sort of segment and only asks for certain information, that would be great.
Yep. Bob? Yep.
Yeah, I apologize. My presentation didn't cover the provider access API. Stanley, you raised the points that we have wrestled with from the beginning. And that is, how do we make this useful to the provider without creating information overload? The ability within the patient access API includes the ability to limit the scope of what you want, both in time and in information types. It also allows you to turn around and say, at any point in time, I only want things I haven't seen. So I can turn around and say, for example, patients coming in, either on schedule or the beginning of the day or the beginning of the week, I go out and I get an update on every patient I'm going to see in the practice. So I know everything that's happened to that patient that didn't come from me. It probably includes things that came from me. But if somebody's been to the ED, or somebody has been to an orthopedist, or somebody has had some other problem, I will have that in the record so I can have that conversation with the patient when they come in to the practice. And because it's only new information, I don't think it's going to cause information overload problem unless you have an incredibly complex patient that's seeing a whole bunch of different providers. And that's kind of par for the course anyway, if that's true. So we've tried to manage it in a way that would allow you to ask for a single patient, ask for the patients for a schedule for the day, ask for a patient for the schedule for the week, have a brand new patient, and ask for whatever time frame you think is important. It could go all the way back to the beginning of the record that the payer has, or it could be just the last year, for example. And that's why we added into CRD the ability to go and add a new patient either through appointment or for them showing up at the practice or the emergency room, so that we wind up giving the provider the ability to benefit from information the payer has. And I want to be very careful here. The payer is not going to have a complete clinical record. That's not the point. What the payer knows is where they have been, the relevant diagnoses where they've had to have them, things that have been required prior authorization. They typically know all the medications. So those are things that are valuable, okay? They don't know necessarily all the clinical details and all the symptomology and all the records that have been collected by the provider. But what we're hearing from providers is, I just want to know that they've been to the ED. I can ask them about what happened. And this way they'll have that information. That make sense?
No, excellent. And to summarize, too much information is not going to be helpful. So the right information, and Dr. Kalan brought up, as well as others, medications. And I would argue too many of us sit in the waiting room with that clipboard on our lap trying to figure out which medications we're on and the dosage. So getting that information directly from the health plan is not only going to be more accurate, but potentially could be a patient safety issue as well. Nobody mentioned value-based care. as a potential advantage of having access to this information. In particular, Bob, you mentioned emergency department visits. If you have a diabetic who has gone into the emergency room on the weekend, you want to know that in order to follow up with that patient to make sure they don't end up back there. Any thoughts on how this could help providers, especially smaller ones, keep track of these patients and make sure that they're getting the care they need and keeping them out of emergency rooms? Any thoughts on that? Yeah, please, Andrea.
Sure. Just as you mentioned, that's a great use case, right? You have a diabetic patient who shows up in the ED, and that will ultimately, if you're in a value-based care arrangement, you will be held responsible for that. So I think it's critically important that providers would have access to information like that, especially for those smaller providers. I think it becomes even that more important because if you are in a value-based care arrangement, I think the margins that you're working with, and I think many providers, small, large, can identify with this right now, but I think particularly for those small providers, the margins are small and every ED visit matters. So I think it could really be a great point of leverage for them.
Great points. Doctor? Yep.
Yep, thanks. So yeah, I would say, in terms of value-based care, I would agree that there's an opportunity in terms of, hospitalization and ER visits, but actually even more so coordinating care between primary care and specialists and even specialists amongst each other. Particularly, I think, in some of the physician-led ACOs where they're fairly broad networks. They may not all be sort of one medical group or one IDN. It can be a challenge sometimes to be able to share information and share it in a timely manner. So I think this provider API represents a great opportunity to help in terms of care coordination, both in an acute setting, but also really just kind of generally managing complex patients who may be sort of getting quite a bit of care and the information isn't flowing as quickly behind them as we'd like sometimes.
Yeah, a great point. And in particular, I should say for primary care, who is usually responsible for coordinating, and they don't always have that information flowing to them. So great point. Stanley?
But as I understand the way the process is planned to work, given this is information at health plan, I would think a provider wants to know a little earlier than having to query a health plan at some point to see if there was an emergency room visit, that there was an emergency room visit. Nice, interesting use case, but there are, I think, situations where a number of health information exchanges already can provide that information almost immediately to a provider when a hospital emergency room or a hospital admission happens. They can notify the primary care physicians on a more timely basis. I'm not sure I get this as a sort of a very timely way. It's a nice way to find out as Mr. Needler was saying, when a patient's coming in for a visit or on a regular monthly or quarterly visits, what's going on with their patients. I sort of hesitate to use it in an emergency, to depend on it for emergency visit type stuff.
Sure. And there's also the admit, discharge, transfer requirement. So if the patient was admitted, then they're responsible for communicating that to the provider. So that's a good point. Let's switch gears and talk about prior authorization. And as Bob walked us through with these three different opportunities for data exchange, let's talk first about this CRD, the coverage requirements discovery. When you think about it from a small provider perspective, how much time is spent simply querying the health plan because you're not sure if that particular service even requires a PA? And so you may even start the process of going through a PA only to find out down the road that it didn't even need that. So let's talk about the potential value. And also from the dental perspective, You folks have already gone down this path with predetermination, so maybe you can talk about how this provides value to the small provider. Rebecca, then Arna.
Yeah, this is probably actually the aspect of this that I might be most excited about. Not because I want it to replace pre-D. I think a pre-D works really well for dental, and I don't necessarily think we need to go down the route of prior authorization. But what I do think is the biggest challenge that we have is we have sort of processing and adjudication policies at the code level, right? So we could have so much variation on what is needed at an individual code, and each individual code, you could have 5 different, things needed for a patient, and each one would have different requirements for what you need to include in the sort of the claim itself. So having this, rather than going to a portal, a payer portal, and searching for those requirements, having it delivered is, I mean, revolutionary a little bit on our end of things. And we're in a really significant healthcare allied professional shortage. We don't have front desk staffs. We're having a hygiene shortage, things like this. So taking the amount of time that people spend on the phone to check these type of requirements and having it available, even if you have to do it a week ahead of time at a push of a button, dramatically different. So super excited about seeing how this will get implemented for dentistry.
Good. Arna? Yep.
Yeah, agreed. So I know we have some members from the dental industry in the audience, and in particular in revenue cycle management. And just to differentiate the difference between a pre-authorization and a predetermination of benefits. So it is kind of rare that we do pre-authorizations in dentistry. It can be plan specific. It does tend to skew towards federal funded plans. So those patients who are on Medicaid or Medicare and are CHIP patients. But like Rebecca said, the amount of administration that we spend on these functions, we have a high dependency on attachments in a lot of our predeterminations around perio charts and radiography and narratives. And knowing the rules at a code and plan specific type will really reduce the administrative burden. Right now, that is some really deep institutional knowledge that exists within our industry, and there's not enough of it to go around. And so what we deal with is just for us, it really impacts access to care and timelines. And so where this really has consequences for dentistry is reducing the time from sending those requests out. And this will pertain a lot to oral surgery. Again, a lot of this is going to be pediatric, is where I really see this giving us a huge lift, and especially in underserved markets. And so this really excites me because these kids they need access to oral surgery and comprehensive care. Right now, we send those requests out, and if there's any error, there's a huge cycle of correcting those and getting them in, and it could be weeks, and these kids are in pain, and it's a really uncomfortable situation to be in. Anything we can do to reduce that timeline, to get the accuracy of the information ahead of time and get that information out and determined in a shorter amount of time, well, it's a quality of life issue for these kids. And so it's really exciting to see that this is something that is coming to the table, because
Excellent.
yeah, we need it, and it's going to be cool.
Good. Stanley?
From the health plan perspective, implementing this requires basically turning their prior authorization requirements, which are probably on a written basis, into something that's, we'll call it computable, that the APIs can handle. So this is an opportunity, I think, for the health plans to review all of their prior authorization requirements, and maybe instead of just automatically translating them into some computable language, to more carefully review them and say, we probably don't need all of this information for this particular code or that particular code. So I think this is a time where maybe the prior authorization processes might be streamlined a little bit by the health plans as they move towards automating this. I know one of the burdens that some of the health plans talked about in automating this was getting those written guidelines into some sort of computable form. Bob, I don't know if you heard anything about this, but once that's done, it's sort of a one and done, and then it's relatively easy to maintain. So hopefully this will be something that happens and maybe even allows for some more standardization among health plans.
Good point. Andrea?
Yeah, Stanley, if that's an outcome of this, that would be fantastic, right? If health plans kind of look at this and say, no, we don't need PA on that, or we don't need such and such information to come across as well to approve a prior auth on a certain item or service. That would be fantastic. I'm optimistic that could be an outcome of this. But even if it's not, I still think this is huge for it to be, computable. And that, a lot of hospitals and providers have full-time employees that do nothing but call these policy manuals that are ever changing. I see a lot of head nods with that, the policies that are ever changing, and to have it in a computable format and just be able to get an automatic yes, no is the potential impact of that can't be overstated.
Yep, excellent. Arna?
Yeah, to add to what Stanley's and Andrea's saying, getting it into a computable format, this is an area of opportunity for artificial intelligence. I've actually seen it happen on the dental side, where we've put artificial intelligence between the payers and the providers to learn those rules. And I mean, it took a good period of time, but the accuracy of those models surprised me. And so that is an area of opportunity. And so if there are anyone in the audience in research institutions that want to take this on and partner with payers, it can be done. It is very complex, and doing it with humans exclusively seems like an impossible undertaking, but we're at a point now technologically where we could actually potentially see that happening if we think about it a little bit bigger.
Yep. Yeah, makes a lot of sense. Bob?
Sorry. In listening to both Stanley and to Andrea and to Erna, I agree this is the opportunity for payers to rethink their needs. And by that, I mean, when you sit down and you can get a good portion of what you need for documentation from the clinical record automatically. The question is, do you need to have something that requires manual intervention on the part of the provider? Does it, and probably requires manual review on the part of the payer? Is that really of value? Is there enough that gets added by having that additional piece of information? If there is, then what we're going to do is over time see that becoming a standardized element in the EHR. So again, we can automatically populate it. What I think is going to happen is we're going to find a lot of the things that say, review physician's notes go away. Okay. And it'll get replaced with things that are critical to that particular service being authorized. I think Erna's absolutely right. I think you're going to see AI as a big part of the evaluation of current written protocols to decide ultimately which elements we really need to satisfy the requirements.
Yep. Excellent. Becca, then Heather.
Yeah, I just wanted to jump in because this is really about small providers, right? On the dental side, if I went out there and was like excited about, CRD and the prior auth rule, it's blank stares, right? But if I show them, the burden workflow that Bob had up on the slide and said, you live and breathe this every day. Some of them are literally closing their office on Mondays so that they can call the payers themselves because they don't have staff to do it, right? So talk about the access access problem that it's creating, that sort of thing. The communication on how the individual small provider needs to talk about it with their tradie partners, with their plans, with the people who provide them the tools to implement this. That is the biggest challenge that we're going to have in dental is how do they talk about it? How do they ask for it? Because right now they don't know anything about this.
Yep. Excellent. Heather?
Yeah, I would just pick up on something that both Andrea and Bob said. I think that another opportunity too, along with looking at requirements as you're building this out, and getting rid of things that just don't add any value, frankly. There's also the opportunity to think about how often plans change their requirements, whether it's the underlying documentation requirements or whether or not something requires prior authorization. I mean, certainly there's cases where maybe a clinical guideline changes and there's a legitimate evidence-based reason to change a guideline, but it is going to be important to keep the both the CRD and the DTR API functions current. And that kind of tags back to my earlier point on the provider API. If physicians or their staff are finding out that this information is being updated and they got a wrong answer on whether or not something required prior authorization, they're not going to trust the technology. So again, it's going to be really important that as we build this out, it's easy to update as plans change their requirements. And again, maybe this is a disincentive to make a bunch of changes all the time because you have to keep this current. So I mean, and to the point about keeping things current, there is the ability in the CRD API to return something to the provider, kind of a confirmation, so they have proof that it told the physician or the staff member that the service didn't require prior authorization, so they're not on the hook if there's a question later on in the game the claim that ends up being denied because prior authorization wasn't obtained. But yeah, I think it's going to be important that these tools are reliable for physicians and staff to trust them.
Good. Stanley?
Yeah, I want to pick up a little bit on a theme that Rebecca mentioned. The vendors that support these offices, especially the small provider offices, because I'm assuming that most small provider offices don't have staff that's going to be building these APIs and inserting them into their electronic health records. The education part of that, I would hope that the vendors are doing the right work to implement the APIs, getting them into the HRs and such, but trying to train the staff or the providers themselves onto what this all means. They don't care what a CRD is or what a EPA is or whatever. They have to understand that they can get this information electronically. They don't have to make the phone calls. They can get good information pushing one or two buttons in their system. And I think that's a lot of the work that's going to need to be done in the industry, whether it's on the dental side, the hospital side, or the physician side. How best to do that, how best to work with the vendors to, again, assure that the small providers understand this and are taking advantage of it. I think that's really a key aspect of what we have to do here over the next couple of years. So I would, again, assume that larger organizations probably have the capabilities of understanding the technology and implementing it. Some of the smaller organizations won't, and they're going to need somebody to come into the office and say, hey, if you push this button, I'm simplifying it a little bit, obviously, but if you push this button, you'll find out if you need PA. If you push this button, you'll find out what you need for PA. And if you push this third button, you'll be able to submit that information. We have to simplify this enough for a lot of the folks in the industry to implement it.
Yeah, well said. Arno will give you the last word on this point here.
Yeah, I'm actually in the chat. Janice Karen made a very good point that a lot of small providers are using software applications that may not necessarily be EHR certified, and don't even have the underlying infrastructure to support this, which this is particularly true in dentistry. As she also mentioned, mental health and some physical therapy, as well as some other tertiary services. And so what we need to start thinking about is at the vendor, it's not just having the vendor support this, it's in the support, it's building out the infrastructure. We need this structured data. We need these elements. We need the ability to be able to collect and transmit this information. There needs to be a consensus. And as for how to address this, right now it's a voluntary ask, which is a huge ask. And so there may be some room for advocacy for federal support here in terms of policy and probably even funding. But this is definitely a significant obstacle to this. Can't be understated that the underlying technologies we're using to run our small practices aren't compatible currently with the infrastructure. We barely have X12 compliance, let alone moving towards a HL7 integration. Doesn't mean we can't get there, but we have to recognize that that is a constraint that we're working against.
Bob, you got a comment on this?
Yeah, two thoughts. I recognize the fact that for smaller providers, you may be using EHRs that are not certified. I think two things are going to happen going forward. Because we have simplified the connection to all payers, they all work the same way now. It's a lot easier for an EHR to add the capability because they don't have to do it one time for United, one time for Aetna, one time for Cigna, one time for whatever. I think we also have the opportunity for third parties to create, if you will, web-based solutions that can go and gather information semi-automatically, but connect to all the different payers. So I think you're going to see some opportunity here for the small EHR vendors and for third parties to help automate the small practices because we've standardized the exchange to the other side, to the payer.
Well, I've got you here, Bob. I'm going to ask a question and then get some responses from the panel. You talked about the documentation coming back from the health plan saying, okay, it does require an authorization, and here's the template you need to fill out. A question for you. You talked about pre-populating these. For a lot of providers, they know exactly which services require an authorization. They know usually exactly what the health plan needs. Can, for example, an orthopedist who knows, they're going to need an authorization, can they pre-populate all of these so they've got it in their EHR as soon as it's requested, they can send it, and that speeds things up even faster?
Well, it's an interesting question. The way it is done right now, if at the time they place the order, the payer says, I need prior authorization and I need to go and have the following questions answered. Basically, what they're doing is they're giving you an electronic form that automatically pre-populates against the EHR anyway. So they have to do something advanced? Probably not. I think this goes back to a little bit of what Heather was talking about. If a payer changes a requirement, okay, and you have a static response, you now have to go and try to catch up. With the way we're doing it now, if a payer changes a requirement, as long as it's structured information, that's taken care of automatically. You don't have to worry about it. If they now require to know if a certain medication is being administered, that's automatic. If they have to know if a particular diagnosis has been made, that's automatic, or it can be. So I think what you're going to see is there's no reason to kind of pre-create the solution, because as long as it's in the medical record and appropriately identified, it'll be taken care of automatically anyway.
Okay. Good. All right. I think we're hearing a consensus with the panel that there's some real opportunities to streamline workflow here. The rule also requires the ultimate decision to come back within, again, 7 days for routine or 72 hours for expedited. In the real world of healthcare, what are these timeframes going to mean? Is it fast enough? Is it doable for health plans? And what ultimately is it going to mean for patient care? And maybe I'll turn first to Heather, because I know it's a really an important issue for your folks.
Yeah, sure. Again, we hope that the technology will be much faster than the requirement is. And, again, we have real concerns about the requirement of 72-hour turnaround for urgent care. We think that's way too long. But I think it's worth noting that that requirement does go into effect before the API requirement actually is on the book. So maybe there's a room, you can see the kind of before and after the way that the regulation implementation has been structured. But certainly I think waiting and following up on prior authorizations when you have patients desperate to get care, particularly if it's the situation they want need an MRI to see if they potentially have cancer, that kind of thing. It's really obviously there's a real clinical outcome thing, but just an anxiety thing for patients. And I think that we're all trying to strive to do better so we can get patients the care they need in a timely fashion. So I think we're hopeful this can really make a difference and enable things to move a lot more quickly. Just so some of the things Bob was talking about, like being able to immediately get the information out of the EHR in a way that can be easily consumed by the health plan. This could really, ideally, all turn into a real-time process in most cases if we do the work that's necessary to make it live up to the promise.
Yeah, I think as Bob alluded to earlier in the program, you may be able to get answers you need immediately with a CRD. So hopefully that 7 days, 72 hours will only be sort of for the outliers. But Dr. Kalan, please.
Yeah, no, I would agree with what you just said. It's a maximum, not a minimum. So, hopefully it's much quicker than that. I think one of the issues becomes, not all healthcare is equally acute. So, if I'm planning a surgery for 2 weeks from now, 7 days, may be fine. As Heather alluded to, if I need an MRI right away because there's an acute issue and the alternative is to go to the hospital, go through the emergency room or direct admit, then certainly I'd like to hear back as soon as possible. So, I think to some degree, once we actually get these systems implemented and, we start to see the ability just to do it to begin with, hopefully, and maybe I'm being optimistic, but hopefully we'll see that sort of morph into the idea that, perhaps there are certain things that can be, auto adjudicated or very quickly adjudicated to where, we're talking about, short periods of time, not even hours, and others that may be more complicated, perhaps a surgical procedure or a medication that's not urgently needed. Perhaps there's a greater window to assess those cases. But I think that's something we'll probably need to see with time. If there are certain use cases where there is a need for, if not real time, much shorter turnaround time based on acuity.
Excellent. Stanley?
Yeah, I'm not sure where those numbers came from. I'm sure health plans had some input into the decisions in the final rule, and we're talking a lot from the provider side here, without a whole lot of input from health plans. But has been pointed out, with the fact that the information now will be more electronic and less paper, it may be able to be evaluated more quickly. I think perhaps just the acute versus, or emergency versus regular is not enough of a triage. As Dr. Callan was talking about, maybe we need to say that there are certain procedures that you need things in 1 day or 2 days, certain things where it's 2 or 3 days and on. Maybe not enough of a cut here just to say emergency versus regular. So I think we're going to need some experience in how well health plans are handling these prior authorizations, and if there will be enough auto adjudication or enhanced manual adjudication because of the additional electronic information, to see if we can whittle down those timeframes. Obviously, from a patient perspective, the quicker you get the prior authorization, the better. And I'm sure there's plenty of situations where there's no reason to wait more than 1 day to get the approval for things.
Yep, good. Andrea?
Yeah, I will just echo everything that's been said. I wholeheartedly agree, especially with Heather's comments. And also Dr. Callan's comments about high acuity care and how that really is a differentiator here. But one other thing that I will mention that hasn't been said yet is we've talked a lot about how to incentivize provider participation in this process, you know. So it's more than just a one MIPS attestation, and it's really meaningful participation. And I think that this timeline piece is really a way to bring providers to the table and say, hey, if you know, leverage this technology, you will get quicker decisions for your patients. To really expedite that care, make sure you're providing timely access to care for your patients, you know, of course, alleviating burden on yourself and your staff as well. I think the timeframes piece is critical to selling this to providers.
It's a great point, and that's what, in particular, Medicare did with claims. If you go back years, they would pay an electronic claim faster than a paper claim. So maybe an incentive. Let's build on that, because I think one of the concerns that I've heard is the fact that not all health plans are required to support the technology. And what does it mean to a small provider if only a percentage of their patients are bringing, you know, to the table plans that are covered under the rule? If it's 20, 30, 40%, what is that going to mean? Is that going to be a disincentive? And the flip side is, how can we incentivize health plans and providers that are not covered under the rule to take advantage of the technology? Arna?
Yeah, so I mean, I think the first thing that's important to note is, in my experience, and I don't speak on the greater medical community, but definitely in dentistry, our Medicaid, the plans that are subject to this are typically federally funded, and they typically reimburse at statistically much lower rates than our private peers. And so, and I'm talking about like 30% versus 60%. And so there's still, like, where we may not have participation on the private plans, we want to encourage that. We definitely make gains on the administrative side, because for providers that are seeing, especially in dentistry, that are seeing patients on Medicaid, it is about volumes. And so any operational efficiencies are going to be welcome. As for incentivizing, this is again coming back to the request from, like, a call to the federal government, both in policy and perhaps funding. It's going to, in my opinion, be a two-pronged approach, but it's a carrot and a stick. It's like, we want to incentivize this, but if we need to, there may have to be a mandate to actually get these in place. But I do see an opportunity that will be really welcome on our end. Any operational efficiencies are going to be welcome.
Yeah, and Stanley, I know early on you mentioned the fact that the difference here compared to 4010, 5010, and I-10 was that the compliance was required from all health plans. So here it's only a subset.
Yeah, and you know, my concern is a little bit of confusion on the provider side. To wait, all health plans are supposed to do that? Which health plans? Who do I send this to? Number one, and number two, I continue to be dismayed and amazed at this industry in that unless there's a regulatory requirement to do something, there is a hesitancy to do it. I've heard that more plans are thinking of, you know, expanding the implementation of these APIs because they recognize the value of them. I hope that's true. And if more plans, even though they're not required to, will implement this, I think you'll get a lot more uptake on the provider side and resolve some of the confusion. I know there were legal requirements that prohibited CMS from requiring this for all health plans, but that said, it'll be interesting to see how well the industry takes this up. I'd love to see 98 to 100% of the health plans say this is a great idea. This is a service to providers and patients and to the industry, and we're going to do that. So we'll have to see how it works out.
Yep. Becca, then Bob.
Yeah, I have sort of an optimistic view and sort of a not optimistic view on this one and implementation. If it goes well, if the industry comes together and makes it work for everybody, then it's going to just be awesome. But if we continue to do a piecemeal where you don't know what rules apply to who and technology only works for sometimes and other things like that, guess what happens the next time we have another API that we want to roll out? The providers aren't going to want to force them to do it. The payers and the technology vendors who aren't, sort of made to apply to these or apply these APIs aren't going to do it. And we're going to have a system that is actually more fragmented and more broken than it is now. We can't rely on regulation for everything. So this is going to be like an actual like industry. Everybody has to kind of get on board with this one. And for me, for dental, I still have a little bit of hesitation. As much as I love, do not get me wrong, this is my favorite thing to talk about. We haven't seen a proof of concept where this works for dental yet. Mm-hmm. I don't know anybody who's done anything in a test environment from all the different trading partners to make this work. So that's where we got to start. Prove to me that it's going to work so that we can roll it out for an industry.
No, excellent points. And Bob, obviously, a lot of the larger health plans are directly involved in Da Vinci, so you may have some insight there.
What encourages me is that every large health plan that I have engaged with, and it's pretty much all the majors, they've come back with the statement that if we're going to do it for the covered plans, Medicare Advantage, Medicaid, CHIP, QHP, we're going to do it for everything. We're not going to go and split our environment between one process and another. It's a question of timing. It's not a question of will they. So that is very encouraging because they cover a significant part of the population. Mm-hmm. I think the next thing that's going to happen is if they indeed do that, this is going to be a competitive advantage over the plans that don't do it. And so we're going to see the marketplace either force the plans that chose not to do it because they don't have those covered plans, or we'll see changes in which plans are viable. My general, and the other piece of it is you're going to see other pressures being brought to bear, for example, by EHR vendors when their practitioners come back to them and say, wait a minute, I don't get it. Why can I do it with this 70% of my patients and I can't do it with my 30%? They're going to be on the hook there and saying, well, the plan's not doing it. It's probably not going to be good enough. They're going to have to go back and start to work with other plans that haven't implemented it yet. The thing we have to realize is a lot of this is being implemented by the organizations that have the care plans, the standards for care. It's not being implemented actually by the payers themselves. It's by the utilization management groups. Mm-hmm. They may wind up providing that service to the smaller payers, and the smaller payers don't have to implement anything. They just use a UN that supports it. Yep. So I think we're going to see some fundamental changes once we get past 2027. Over the next couple of years, the market's going to both coalesce on organizations and the viability of particular payers.
Oh, excellent point. And I will say, WEDI's had some of the early adopters, in particular, Cambia Regents out in the on the West Coast, and they're reporting some significant savings. So I think part of our job as an industry is to highlight those, to spotlight and say, listen, it's in your best interest because there are some value points to adopting the technology. Okay, so I think we all agree it's a great idea. So if we ask the question, if I'm a small provider, I'm excited about this, the opportunities are there. how do I get started? Obviously, I've got vendors that I work with. I work with a clearinghouse. I work with an EHR, perhaps a practice management system vendor. What are some of the first steps that that I, as a small provider, will need to take? Obviously, make a phone call, right, Stanley?
Well, there has to be some sense of education.
Mm-hmm.
I think that although we tend to have our small providers depending on vendors to educate them, but we don't want to be in a position where a vendor says, well, look at all these great new features, and for an additional $175 a month, we'll implement them for you without really explaining what they are. We have to do a good job of getting the information out to the industry about the benefits of all of this. And there are, we've discussed all this, there are clear benefits for almost everyone in doing this, provider, health plan, and patient especially. So we've got to get that information out. And then we've got to show that, what the benefits are and how happy everybody's going to be once this is implemented. We've got to stay away from, hey, this is just another federal requirement. We've got to say that, yes, it happens to be a federal requirement, but it's done for some very good reasons based on the work of some very important information, of some very important organizations and some very good people. So, education and explanation to the provider community, I think, is key here.
Go to Kalon and then Andrew.
All right, thanks. Yeah, so I would tend to agree. The first bottleneck here is the EMR vendors need to actually be able to implement the standard. So there will be a little delay before providers can actually use it. But I think the real key is what Stanley just alluded to. Who's going to pay for it? So for a small practice, margins are already tight. People are already struggling a little bit with administrative burden. So there has to be some business case here to say that, if I'm going to be asked to pay for it as a provider, what's in it for me? So less staff, some time savings somewhere. Otherwise, I think that's going to be a big barrier to adoption on the provider side. If it costs anything greater than zero to the provider, the provider is going to sort of question, what am I paying for here?
Yeah, absolutely. Very important. Andrew? Oh, I think you're on mute.
My apologies. Sorry. I'm pointing the finger at myself here and saying that a lot of this, as others have mentioned, has to do with provider education. And I think it's really making sure that, we as, the AHA and other stakeholders, Heather, I won't put you on the spot, but also the AMA. It's imperative that we educate our members on, and also, as kind of Rebecca alluded to earlier, in plain language, and not talk about CRD, DTR, but show them this is how this new rule will impact your workflow in a very positive way, and bring them to the table. So I think it's that provider education piece, which again, everyone on this call probably has a part in. And then number two, I also think ONC certification, as we've talked about, is just critical here to really, build that bridge between what the payers are building API wise and connect it to the providers on the other end. That's critical.
Yeah, excellent points. Bob, then Rebecca.
Yeah, Rob, I think one of the things that you noted early on was, or a while ago, was Cambia's experience. And I think when you look at what will drive it into the provider space, it's the fact that the experience there from the provider organizations that participated in their early trials around burden reduction found a better than 50% reduction in the number of prior authorizations they submitted, because they knew in advance they didn't need one. So they just didn't have to go through the overhead and the work to do it. The second thing was, of the ones they did submit, they got answers to something like 70% of them in real time. So they didn't have to wait weeks or days or get something back on a portal or whatever. That's a huge savings in personnel overhead for a practice. So I think these are the kind of things that will drive it in. It's not additional burden, it's reduction in burden, which was our goal from the beginning.
No, excellent point. And we've certainly heard from providers albeit maybe the larger ones that have dedicated staff, not just for prior auth, but by payer. And it's a huge burden, very expensive. And so by eliminating that, automating that, you can redirect those resources better places. Rebecca, then Stanley?
Yeah, I think for us, like the provider is almost the, I don't want to say the last who need to know, but for the non-government affiliated programs, it's the employer programs, the employer purchasers who have to know. And I don't necessarily think that they get looped in on questions, on asking, how do your plan support this? And so starting there, and I mean, we have definitely, the ADA definitely has a role to continue educating and talking about it. But if I educate my member and say, you should be asking, is this available? And no one knows what they're talking about, the rest of the industry doesn't know what they're talking about, it's not going to go anywhere either.
Yep. Yeah. Very good points. Stanley?
I think we tend to lose sight of using patients as a place to bring some pressure on both health plans and providers. Obviously, the improvement in prior authorization would be a great benefit to the patient. So if we could find a way to let patients know that these opportunities are out there for both health plans and providers, and have them say, at least the ones that are familiar with us, hey, doc, I know we have prior authorizations. Does your system, can I get a quick prior authorization to turn around on this? Have you automated that? Something along those lines. I think that there's another potential pressure point. I mean, the patient access API, I think there's some privacy and security issues there. So patients would probably want to know about that and at least have the opportunity to tell their doc, yeah, you can get all this information, or no, I don't want you to get that information. I'm not giving you permission to do that. But again, on the education side, we've got providers and patients that we need to reach out to. We don't really have that many good organizations to use to reach out to patients on this. But somehow we're going to have to figure out a way to educate them.
I think that might be an excellent point to end on. I think we learned a lot, but I think there's a lot of learning left to do. And in particular, we want to hear from folks that have gone ahead and done this. I think Rebecca and Arna, you talked about, let's prove the use case for small providers, for dental offices, and sort of build momentum. And I think, we don't want it to be the chicken and egg issue where the plans are saying, I'm going to wait till the bulk of the providers are ready, or the providers say, I'm going to wait until the bulk of my payers are ready. We have to move together to really achieve success here. So with that, Michael, if you can pull up a slide. I just wanted to say thanks to a bunch of folks. Obviously, our panelists, Bob, Becca, Summer, Paul, Heather, Arna, Stanley, and Andrea. Phenomenal discussion. I appreciate that very much. Thanks, as always, to our wonderful sponsors, EdFX and MCG, for their continuing support of WEDI. Thanks to the audience. Great discussion in the chat. Thanks to Michael McNutt for making things run so smoothly, as always. And the conversation does not end here. On Wednesday, we have our small payer focus. And then at the spring conference, we've got a whole track on prior authorization and data exchange, and you will not want to miss that. We've got, again, some of the very expert speakers that will not only entertain us, but educate us as well. So with that, I will close, and everybody enjoy the eclipse if you can see it, and look forward to seeing you on future WEDI events.
Thank you.
Bye. Thank you.